So when we're approaching this in the clinic, we have some key questions. Why are we using GnRH agonist? Is it for fertility preservation or cancer risk reduction or both? What's the patient's current menopausal status? Are they in the full reproductive phase? Are they perimenopausal? Is chemotherapy likely to induce menopause? And should the GnRH initiation precede anti-estrogen treatment? And the question here is probably related to how likely it is that the patient's going to quickly transition into menopause, how high risk the disease is, how quickly you want to get them onto anti-estrogen therapy.
The use of concurrent GnRH agonist significantly reduces the chance of chemotherapy-induced premature ovarian insufficiency. It reduces the rate from, in the meta-analysis, 30% in the control arm to 14% in the treatment arm. And that's really quite substantial and amazing that we can accomplish this in our clinics pretty easily. This appears to work in all of the subgroups, including younger versus somewhat older women, ER negative versus ER positive, regardless of chemotherapy regimen, shorter versus longer chemotherapy. So this is a tool that's available for all of our patients. Pregnancy rate was practically doubled in the patients who received GnRH agonist, up to 10% versus 5% with control in our younger patients. And I really like the use of pregnancy rate as one of the primary endpoints of these studies. It's a much more tangible endpoint than return of menses, particularly when we're thinking about this for fertility preservation.